So those of you who work peds may be a little bit bored with this, but we're gonna, if you now work peds from the beginning, from a primary care perspective, you may learn a few things. So, a little bit about me. Okay, so when we start this class, you all will be pleased to know that this, the 7th edition of the Burns book, is the best edition so far. So when I went through my program, ancient history, it was the 3rd edition, and it was that thick, and it was about only about this tall. The edition before this was over 1,000 pages, and it was the big book. It was like you could hurt yourself carrying it around. It was hardcover, and so they took a lot of the extraneous stuff out of it, which is great. So the chapters are shorter and more condensed. So feel privileged that you don't have to read the same amount that 2 class periods, 2 class semesters ago did. As I look in this book, the good thing about, so I'm going to talk a little bit about professionalism first. Being a pediatric nurse practitioner, I belong to a professional organization, which is NAPNAP. That's our professional organization. And in being involved in my professional organization, I have gotten to meet some of the movers and shakers in pediatric nursing, as far as practitioners are concerned. And when I look at the names in the front, Dawn, Garzon, Matt, that's what I can't pronounce. She's gotten married. So this MAAKS. I have worked with her on committees as well as Nan Gaylord. Nan Gaylord works at University of Tennessee, Knoxville. And then I get to the contributors, and I can go through there and name about 6 or more of people that I've had the privilege of working with. And when you get the privilege of working with movers and shakers of the thing that you enjoy doing or what you're going to be certified to do, it makes you a better provider, because then it's got your brain moving and shaking with the people that do the moving and shaking. It keeps you sharp. It keeps you on point. So you will like this. You will hate this book, but you will also just trust me. This is much better than it was. But this is a lot of information to learn in 1 semester. It's huge. There's no way to learn it all, get it all. So give yourself a break. Okay. My whole MP program was based on this book. Okay. So use your PowerPoints for your chapters as a basis for your reading and in-depth reading. Okay. Because that will help you focus where you need to read and some of the stuff you really don't need to focus on. Because if they're focusing on it in their PowerPoint, that means that it might be some significant information. Okay. So, and don't be overwhelmed. Somebody was already talking about being overwhelmed. Dr. Blankenship does an excellent job of not letting you get overwhelmed in this course. Okay. There's just so much going on. Now, as we've already talked about, PowerPoints and reading are very important, and using the PowerPoints as a focus. What I will discuss in class will augment, not replace, your readings and your PowerPoints, okay? So now, I'm going to say this before we go any farther. We're going to talk about a lot of stuff today, but I am focusing on development, pediatric development, okay? So that's where we're going to focus that today when I talk. You've got either this week or for next week, the infectious disease.
As part of this week, the videos are already uploaded, the PowerPoints are there for infectious disease, and what's chapter 30?
Immunization. No, 31 is infectious disease, but 22 is immunization.
Yes.
Okay. So when you get ready to do 31 on infectious disease, sit down. Get you something to drink, a snack. Make sure you've gone to the bathroom. There's 125 slides. Okay, 125 slides. It's a bunch. Okay, take your time, pace yourself, get up, take a break, walk around. Don't feel like you all have to do it in one setting. Now, the immunization chapter is very short and sweet, but the other one is huge. So Just telling you. And I don't understand why they did this, why they put so much into one chapter, but they didn't ask it. So it is what it is. Questions so far? Oh, I do want you to feel free to, number one, stop me and ask a question. Number two, correct me when I'm wrong, if you feel like I'm wrong. Those of you who work specialty needs, you're going to know a whole lot more about endo than I will ever know because you work in it all the time. I know it from a primary care perspective. I send them to you. Okay? So don't be afraid to share information, especially if it's going to contradict what I say, because what I'm sharing with you is my experience and my knowledge base. Okay? So I don't take offense to that. And if anybody does, then they're not much of a teacher. All right, so me. This is a little bit about me. I've been trying to get to know you. I started out in the Associate Science program at this university in the fall of spring of 1983. Yes, I am old. I am old enough to be most of your parents, which just really bothers me. But I had an Associate Science from Western and a Bachelor of Science from Western. And then I went into practice. Thought I was going to be a med-surg nurse forever. I got my certification in med-surg. We moved to Northern Kentucky. And I took a job as a school nurse in a small county school system and almost shut the school system down with my lack of knowledge. Not kidding. So that was my introduction into pediatrics. So I had a fast learning curve. So when we moved back to Bowling Green in 1990, I got the opportunity to work across the street. I was the RN supervisor in the pediatrics department over here at Grace Fielder. Learned a whole lot. Then I went back to school health with Warren County, and then my husband moved me again. This time we moved closer to Moorhead. If anybody knows where Moorhead is. So, that's when I decided it was time for me to go back to school. After a few years of being just a mom, I decided it was time to go back. I got to go on a medical mission trip that changed my life. You know, you're supposed to go and help other people, but usually you get changed more when you do something like that. So I came back and I started back to school, and there was only 2 places in the state of Kentucky that had a pediatric specific track. And that was U of L, which wasn't going to happen ever. And UPEP. And that was right down the road. So I started on my 40th birthday in my NP track. So what a life, where you call that midlife crisis? That was my midlife crisis. So I got my master's in the PNP track. And then I decided with 2 kids in high school and working a full-time job to go back and get my doctorate. Somebody should have slapped me upside the head. Dr. Eve Main and I, she was a class ahead of me, but we were there at the same time. Eve and I have known each other for years and years and years. So it was really nice to have a connection with somebody while I was in school. So my project emphasis at the time was in pediatric sports injury prevention because I had 2 athletes at my house. And it always seemed that we were hurt or doing some kind of injury. So, but anyway. So beyond that, I have done a little bit of everything over the last 38 years. I've done med-surg, I've done psych, I've floated. Here's my floater. I have done home health. There's my home health. I've done some ICU. I was never trained in ICU, but I was one of those that they was pulled to ICU because I was dumb enough to say yes. I've done school health where I've been an RN in 2 different school systems and a nurse practitioner in a school system. That would be, if I could have one job, that would be my ideal job, was to be a PEDS NP in a school system. That would just rock. And so I've also worked in a primary care PEDS clinic, and I've worked in several family practice clinics as a PEDS specialist. And then to be even more stupid, I went back and got my pediatric mental health specialist certification in 2017. So what does that doesn't get me much of anything. That not even 50 cents, and that piece of paper get me even a cup of coffee anymore. So I have a lot of education and a lot of experience. And experience, for the most part, trumps education. Education is important, but experience is also important. And the more experience that you have in doing anything, whether it's you got this particular patient and you spent time researching and working on it and figuring out what was going on, that will stick with you longer than probably anything you read, and it kind of goes in and kind of goes out. So, but that's just me. That's my 2 cents. So we're going to start with child development. So some of the principles of development is that development is a very orderly thing. It's and sequential. So it is very predictable. So the pace of growth and development will vary between each child, and it's very specific. So I may have a 2-year-old in this room and a 2-year-old in that room, and this one's at the 5th percentile for his height, and this one's at the 99th percentile for his height. They were fed well. They come from nice homes where they had no environmental factors that would have caused any problems with their growth and development. So I got a parent complaining, why are they so short? Why are they so skinny? What's the problem? But there's not. There's really not a problem, because every child is different, and genetics plays a huge role in that. So you go through the things, it's like, well, they're doing this and they're doing this. Developmentally, they're right on task. Are they eating really good? Blah, blah, blah. So you run the questions with the parents, so you have to reassure them that everything is going just like it should. But it's just going to be who that child is. It's just going to be. Also, it occurs in a head to toe or cephalocaudal, proximal, distal. So the core will develop faster than the extremities and move outward. And our developmental abilities will increase over time. So I talk about with parents, the first year is all about length and weight. The second year, what happens in the second year, you all? What do they learn to do? Talk and walk, and they learn to manipulate things, feed themselves, use utensils, use a sippy cup. So the degree to which their development is increasingly organized, okay, and it will differentiate. So the first year is all about weight and height and length, and the second year is all about cognitive. To me, that's how I differentiate. It's all about the cognitive, okay? Now, there are certain periods of time that are very, very crucial. Am I not doing something right?
No, you're doing fine.
Okay. There are certain periods of time that are very crucial to growth. Can anybody, let's start from during our neonatal or 18-year-old. So what's a period of time that is very critical for development? So yeah, all of pregnancy is a very important time, right? 0 to 3 months are very important because so much happens, so much replication happens. We've got, if you've got issues with hearing, or kidney, that usually is all happens before their 3rd month of conception. So, and those are kinds of things that you need to know, okay? If you're going to do a lot of pediatrics. But there are certain things, both environmental and internal, that are going to affect that. What else? What else can affect growth and development besides just things that happen during the prenatal period? Let's say after they're born. Oh, come on.
The pregnancy or the delivery itself.
Delivery itself can cause birth traumas and injuries. It can cause lifelong problems. Anybody else? During this first couple of years, think about it.
Like if they're exposed to chronic stress.
Yes. And we're going to get to that actually. So hold that thought. That's really good. Anybody else? Right. Oh, we don't need smoke exposure. No, not at all. No, nobody smokes. Or cooks meth. Or smokes pot. Or, any of that kind of stuff. Right? Yeah. What about disease? Or chronic conditions that they're born with, not necessarily from birth trauma, but just say you've got a preemie who's born with a condition called bronchopulmonary dysplasia, BPD. That's going to affect that growth and development down the road. Or a child born with CF or cystic fibrosis, that's going to affect. So all of those things can affect growth and development. What about feeding? I mean, I've got a baby today, that was doing really great, gaining weight really well. And in the last 30 days, at 2 months, they only gained 10.5 ounces in the last 30 days. So you all might say that that's good, but it's not. We expect a 0.5 to 1 ounce weight gain a day. So they gained 10.5 ounces in 30 days. But they were on that track before. So what's the problem? This baby looked skinny and not as developed today. Well, so I had to get, and part of the reason that they were in was to discuss that. They were having issues with regurg and vomiting. And they spit all the time. Well, let's talk about how much do you say? Well, it's a lot. And you're just now telling me this. You haven't said a word. Haven't been in a month and you haven't said a word. So feeding, not feeding. We've got those periods. God love their hearts. There are some people that don't need to have babies at their house. And love their hearts. And I'm not going to go into the why, but they just don't get that the babies have to be fed, especially initially 2 to 3 hours, and how much they want to limit how much the baby gets. The baby's still hungry. The baby will but they've already had this much formula. Well, how long ago was that? Well, it was 4.5 hours ago. I said, but this is a 1-month-old baby. The baby's got to be fed more than that. So you've got education factors. There's all kinds of things that you have to deal with. Okay. Now, development is a continuous process, but it is often without smooth transition. Okay? She's already ahead of me, way ahead of me.
Didn't mean to keep moving. I'm sorry. if I
That's
did that.
okay.
I was just looking at that. I did that.
You did that? That's okay. All right. So, is theory still a big part of nursing? Okay, because when I was going in, everything had to be connected to the theory. The thing about child development theory is that whether or not you think about it or whether or not you realize it, all of these theories have some way shaped how you see or will see kids and their growth and their development. So Piaget's operational stages, which is your sensory motor in the first one, and your pre-operational, concrete operations, and formal operations. You remember that? Okay. So, and then Freudian. Freud is id, his ego, and his superego. Well, then Anna Freud applied it to children. And then we all know Erickson's stages, right? You've heard that talked about. I am not going to go over these, but you might want to refresh yourself on some of these. They're in the book. There's that chapter 8, page 63 starts talking about the theories. I'm a theory person. Maybe because that's how I was taught. Maslow, my gosh, that used to be what everything in nursing, Maslow's hierarchy of needs. If we meet the basic needs, then we can move up the pyramid to the most, to the self-actualization, if I remember correctly. So, what theory do you use? Do you use a theory? Do you specifically use a theory? So working knowledge of each one is going to be really important, especially when you're assessing kids' learning, speech, thought, kids playing with themselves. I don't know how many times I get parents, he plays with himself all the time. Every time I take his diaper down or I have his hand, it's like, that's okay. It's not competitive. It's okay. Neither is a little girl if she's playing with herself. And you have to talk about those kind of things, but you have to know enough theory to be able to talk about what's normal and what's not. But not only is it going to be really important that you have enough theory to assess children properly, but it's also going to be important to assess the parent. Now that sounds weird because this is a pediatric class. But as we've already talked about, some of our parents don't have the mechanism or the knowledge base to be good parents or to know what to do, how to take care of their child. So we have to kind of, can you all see me? I'm too short. We have to take theory especially like family systems theory, and assess our families to see where they're at. How much teaching are they going to need? How much information do I need to give them? I'm going to have to spend a whole lot of time with one set of family, where over here I have a different dynamic in that family, and I'm not going to have to spend as much time teaching because they're going to get it better. Yes, ma'am.
Would you like me to control?
Oh, no, I'm good. No,
Okay.
that's good. I'm good. You know me, I roam. So why is it really important that we teach our parents about about kids' developmental state? Because if you ever known a parent, either your own or somebody else that you knew, had unrealistic expectations of a child, it happens a lot. Especially if you've got a kid who's really tall or big for their age, then the expectation is that they're going to act older than they are. But when they act their age, parents don't understand that. So it's really important when we're in that room, if we're doing a checkup, that we talk about developmental. We call this anticipatory guidance. What do you expect? This is what they should be doing. This is what you should expect. Anticipatory guidance is very important. What's coming next and how to prepare. So I had a long discussion with a family this morning about a 15-month-old who's already saying, no, I'm not do it. And throwing things and throwing temper tantrums, which is a little early. But we had a sit-down discussion about temper tantrums and how to manage a temper tantrum and what's appropriate, and parents sticking to their gun. And when that child looks at you and say, I hate you, how are you going to deal with it? So you have to look at the situation and look at the child. Okay, so screening. Screening tools are going to be very important. And this is some of the stuff that we talk about that you've already got access to, okay? Okay. So this is going to be our first level contact. We use a lot of screening tools. Why do we use a lot of screening tools? Well, number one, it's cheap. It's quick. And it can help parents to stimulate questions or remind them of questions. Also, see this thing right here? Y'all have access to this online. This hangs above my desk. See all those little dots? These are the things I have to cover every time I have a well child exam for that particular age. It's on Blackboard. That thing right there. That sheet right there. So, because you all heard about those quality measures things, we don't have a lot of them in PEDS, but we have a few. And part of that is we have to meet all of these guidelines for any of our Medicaid patients. So, screening tools are part of that, okay? So, we do screen for areas of language, motor, social, emotional, and cognitive. So, some of the different types of tools that we use are the ages and stages, or the ASQ, and I'm going to just there are around the 3 that we use, because Medicaid requires us to do them at these ages. I'm going to start that one there, and this one here, so you can just review it. I'm going to start this one, and you can have it over. So these are developmental questionnaires covering language, gross motor, fine motor, problem solving, and personal and social. Parents fill that out in the lobby while they're waiting to come back. We have to do some kind of developmental screening tool that is approved, and this is one that's approved, and it's fairly easy to get. My boss has bought the kit. Now, technically, there's one of these for every month. You don't have time to use those for every month. So, now, the PEDS, the Parent Evaluation Developmental Status, is another good one. I don't have that one. The Modified Checklist for Autism and Toddlers is, we call that the M-Chat. That will be one of your online, that is this thing right here. So we do this at 18 and 24 months. This is when we start screening for autism. And usually that's when, if there are enough issues on this, this is when we have them start to get them into for evaluation. And it can change from 18 months to 24 months. They can be doing fine at 18. And 6 months later, they can be having issues. So,
All of these are in 547.
yeah, this one is. Those will be.
Yes, the ASQ is the only one that is not there right now, but it will be. But everything else, I believe, is under resources in 547.
The other one thing that we have to do that Medicaid requires is a lead screening. We do this at 1 month, 2 months, 4 months, 6 months, 9 months, 12 months, 18, 24, 36, 48, 60, 72. They get tired of looking at it. Now Medicaid also requires a lead test somewhere between 0 and 2 as well, not just a screening tool. You've also got the ASQ, that's the social emotional. We don't use that very often. And then the pediatric symptom checklist. I don't have that with me. That's one of the ones that you've got. That's another generalized screening tool for issues. And these are all also listed in your book in table 10-2, starting on page 100. So screening tools are a huge part of what we do. And I brought this today. Okay, so this was my morning. Okay, these are my patients that I saw. You see all the circles out beside the names? See all the circles out beside the names? So every circle out beside the name means there's a piece of paper that I have to come up with to go with that patient. And if I don't have it when I sit down and start putting everything together, then I have to go find it. So all of those circles out beside the name are pieces of paper. And when you do, and this was just a morning, so you gotta see the ones from the front and back, and when there's 30, and it gets long, and you're looking for pieces of paper everywhere. So there's a lot to keep up with. But it's really important. We've seen, and the other thing we didn't talk about is the Edinburgh postnatal depression screen. This is something new that was required by us by our quality measures, which is great. You wouldn't believe how much postpartum depression we have identified after we started doing this. And we send them back to their OB, because if a mother is depressed, what can happen to the child? It can die. Again, no, feeding issues, and it can end up in social services. It can be beat. It can be abused. So it's been a huge, huge kind of thing. So let's say we identify some of those delays. Okay, how do you talk to a parent when there's something abnormal going on?
Did you ask the parent, have you noticed anything?
Most of the time, my first question is, do we have any problems or concerns today?
Yeah.
Well, Johnny's only got 3 or 4 words. Okay, let's talk about that. And we'll start talking about that. Or he's not walking. Okay, so when they start bringing those up, then we explore it just a little bit. I saw a kid today who's 10. I've been seeing him for years, and it's taken mother forever to really understand that her child is autistic. Really a long time. And school had to tell her because she wasn't listening to me. So I let that happen, and she's still in a certain amount of denial with it. I don't know why, but she is. So, but most of the time, parents are usually aware that something is not right, and they'll bring it up. So if I identify something that's not right, I show them, okay, like the child with the weight this morning, 10.5 ounces. I showed them the growth chart and how we had gone down and dropped percentiles just significantly. So when you've got data to show them, that's helpful. So effective communication, especially when you're talking about abnormal screening tools and abnormal results, is going to be very important, because you can tick a parent off, you can make them mad, you can cause them to get their hackles up really quick, because that's my baby. You're telling me there's something wrong with my baby? So you have to be really careful in how you approach it. But we all know that early identification improves outcomes. That's in anything, right? That's in any disease process and any kind of issues. So it is really helpful. This is what I have learned, to use a strength-based approach. So you start out talking about the positives. What's your child's doing this well or doing this well. And then you kind of discuss what's going on and where we should be. You may get the anger, you may get the denial. The grief process may start almost immediately. You can't be abrupt with your parents. You've got to be willing to, no matter how many patients you've got waiting for you, you've got to be willing to sit there and talk for a few minutes. Move as fast or as slow as the parent needs, and you may need time. They may need a lot of time to adjust. And if that's the case, you send them home. Okay, we're going to do this. This is our next step. Why don't you all go home, sit down, talk, write a list of questions, come back next week, and we'll sit down and we'll talk some more. Give them time to process. Okay. And if you've definitely got those with a confirmed developmental delay, failure to progress, or those with developmental regression, they're going to need immediate referral for evaluation with a developmental specialist. The problem with that is what?
6 months.
Months to get in, because we have very few out there to test.
I was gonna ask that, yeah, where would you even send them, yeah.
Well, there's a waiting list to get into Vandy's. We have 2 people. We have a lady by the name of Emily Klein, that's a social worker that is certified to do developmental testing. We have Dr. Liz Sternberg here in town, who is a developmental pediatrician. She works through Fairview most of the time, but she does independent developmental testing. Hope Ridge, which is out on Russell Road, I think. National Road, maybe. Hope Ridge. Big Red School, Big Red School is a place as part of the university that has basically classes for autistic kids. And they used to do testing. I don't know if they do that anymore. Life skills. Again, the waits are horrendous. The one in Louisville. Thank you. Waskoff Center. A year or longer. So if any of you want to go into being a developmental testing specialist, OMG, you can make so much money and never have to worry about work ever, having patients ever again, because we need so many of them and there's so few out there. Now, school psychologists will do it, but oh my gosh, getting that done as well is also very difficult. So even though you may have a developmental issue and you want to get them referred as quickly as possible, getting them actually evaluated may take forever. Now, if you've got one under age 3, we can send them to first test. So we can start the process. We can start the speech language. We can start PT, OT, things like that with them, even though we know there's a developmental delay, but we don't have a definite diagnosis. Okay.
First steps is also covered too. It's not like
Correct. They come to the house, they do the evaluation, and they actually do the visits with the family at the house, which is great. Except during COVID, it's been kind of hard. So, and if you're still waiting for developmental testing and you need some other resources like the first steps, if you've got older kids that are over 3, then what do? We do here in town, we do have a place called APT, or Associates in Pediatric Therapy, and they do speech, OT, and PT, and they're very good. We've got kids that, especially our autistic kids, sometimes need feeding therapy. Finding that we used to have a great person at the medical center. She was a speech pathologist, and she did feeding therapy. She's no longer there. So we've lost that resource. So in an area where you have a major universities like at UK and U of L, Bandy, you're going to have more access to specialists than you do here. But again, getting in is the problem. So you have to be aware of your resources. So, and that's an issue. And especially, this is sad to say, our patients with state insurance we have more trouble getting those patients in because there are fewer opportunities, fewer places that will take that insurance for the testing. So let's get to the basics. Let's talk about the newborn. Newborns have to be evaluated by their PCP between 48 and 72 hours post-discharge. If it's a breastfed baby, we want to see them the next day after they go home. Every provider is a little bit different. So what are you going to need to know about this baby before they come in? If you can, you want this birth history. You want to get the discharge summary from the hospital if you can. You want to know, were they spontaneous or were they C-section? How many weeks were they? Is there a possibility of prematurity? APGARs. Did they pass their hearing screen? Congenital heart screen. Did they give their hepatitis B? There's a lot to know when a baby comes in. We have a lot of babies now who test positive in their cord blood or for drugs. And those babies used to automatically be taken from their parents and put in social services. That doesn't necessarily happen anymore. It depends on what the drug is. Yep.
Which drugs do they not take for kids? Just so I
Pot.
had to-
Yeah.
Pot. And then, of course, if they're on Suboxone, then they're going to show positive. And if they have shown clinical where they have been monitored in a Suboxone clinic, of course, they're not going to take that baby away. And if they have a prescription for an opiate, they're not going to take that baby away. Could they be abusing that opiate? Sure, they can. But if they got a prescription for it, they're usually not going to be, they're not going to take the baby.
For like ADHD or narcolepsy or something like that, when you're pregnant, can you continue to take?
There are, well, I've had mothers who were on antidepressants that she and the OB and the mental health provider felt like it was in the baby's and the mother's best interest to keep her on an antidepressant because what might happen if she went off of it would be detrimental to the baby. So it's a crapshoot.
Kind of like that seizure medicine.
Right.
Like you can't take
Right.
them off in case.
Right. Exactly. So that's where your high-risk pregnancy docs are going to come into play, and they're going to manage hopefully that very carefully. But even with that, you've got issues with those babies when they come. So we need to know mom's history. Is mom HIV or group B strep positive? We're going to learn when you do the immunizations that there is on the horizon a immunization for group B strep coming. So we need to know how many babies that they've had. How many times have they been pregnant? Do we have another child that has delays or chronic health conditions? And all the other wonderful stuff that can affect a baby. So we're going to look at, of course, vitals. Bilirubin is one of the big things that we're going to be concerned about. If you don't know what bilirubin is, if you think about it in adults, it's the jaundice. So in babies, it's after they've cut the cord and there's a certain amount of the blood that comes back into the baby and they have to get rid of it. So some of that goes back into their skin and we have to feed them really good and flush their system and get that out. But there can be pathologic jaundice and there can be physiologic jaundice. And any breastfeeding mother is going to have a baby that's going to have some physiologic jaundice. I haven't seen a case of pathologic jaundice in the 16 years that I've been doing this or been an MP. We have to know, we have to know if they're breastfeeding or bottle feeding, which type of formula. I've got lots of mothers that breastfeed, sort of. They pump and feed, or they'll pump and feed, and then they might give them a bottle, or maybe if they didn't pump, if I didn't get much, then I'm going to give them formula, or I'm going to give them a bottle of formula and then give them breast milk afterward. And I don't care. Just feed the baby. That's all I want you to do, feed the baby. But it does make a difference because stools are different with breastfed babies than formula fed babies. And if there's a combination, then that's even different. So it makes a difference when you're talking to these parents. Now, breastfed babies have a tendency to not gain their birth weight back very quickly. And that's because mom makes colostrum for the first 3 or 4 days. So they're not getting a whole lot to eat. And their weight when they're discharged may not be their lowest weight. So we don't expect them to necessarily, the goal is to be back to birth weight by the time they're 2 weeks of age, if they're just completely breastfed. We've already talked about, we expect them to gain 1/2 to 1 ounce of weight per day. And infants who've lost more than 10% of their newborn weight should be very, very, very closely monitored. Something's going on. Okay, head to toe physical exam on a newborn. This is table 9.2, page 78. That's something you probably need to review really well. Let's talk about the difference between a cephalohematoma and a caput succedaneum. Which is which? Anybody know?
That comes from like the vacuum.
Yep. But how do you look at a baby and tell this if this is a cephalohematoma
One calls it a suture line.
and one
does not.
which one's which?
The cephalohematoma cross.
No,
The other way around.
cephalohematoma does not cross the suture line, but caput succedaneum will. So we're talking about that vacuum. Everybody knows what we're talking about when we talk about the vacuum, right? And it puts so much pressure that it may cause this little pooling of blood on the back of the head, and that's a caput succedaneum. And it crosses the midline. The cephalohematoma does not. And so sutures are really important. You need to look for that fontanelle open, soft spot. Is it sunk in? Is it bulging? Both of those two things are very serious. They also have a posterior fontanelle. You need to check that. And do they have, during birth, did that push hard enough on the head that those sutures overrode each other? Okay, especially the two parietal sutures. The two parietal bones, did they override each other? Or did they override the frontal bone? I've seen that where the parietals override the frontal bone and you've got something like lurch look to the face. Eyes, ears, nose, and throat, very important. A lot of times this is where we first pick up that there's some kind of a congenital genetic anomaly. The shape of the eyes, the philtrum, the nose, the mouth. Down syndrome specifically has a very specific look to it. Kids born with fetal alcohol syndrome have a specific look. Then there's certain other chronic things that are very, very important. So you've got to, let's talk about the uvula. When you're looking in the throat, is it bifurcated? This is going to sound, I know we have 3 guys in here, and don't take this wrong. It looks like a scrotum with balls in it. Sometimes it's bifurcated, okay? Instead of just normal, just hanging down. Sometimes the more bifurcated it is, the more the likelihood that you've got not necessarily a flat palate that's open, but you can have an open palate and still have the skin over the top. So palpating the roof of the mouth is going to be really important to see if it is open underneath the skin. So your bifurcated uvula is going to give you some clue when you first look in. So that's just a pearl. So I'm doing it forever. Chest. Chest circumference should be about 2 centimeters less than the head mass or head circumference. Sometimes babies will have masses under their nipples, even boys. Okay, that is leftover hormones from mama, and it should go away. Very seldom do we have that it doesn't go away, and I've had maybe 2 in my 16 years that after they've gotten to be about a year old and they still have that mass under there. It hasn't gotten any smaller. I had to send them to surgeon to have that taken out. So you just have to keep a look at it and assure the parent that it's supposed to go away. Murmurs, breath sounds, If you don't know how to grade a murmur, you need to get online and listen to some YouTube videos and watch some things and learn how to grade murmurs. Most babies are born with some kind of a murmur because the trauma of birth and the rearrangement of all the fetal circulation. So initially they may have a little murmur, but usually within a couple of days that goes away most of the time. But sometimes it doesn't. So our abdomen, it's gonna be very scaphoid and they have bowel sounds. Having that first bowel movement is very important. Why is it very important? Yeah, because we have what? Obstruction. Thank you very much. We could have an imperfect rectum. Or anus, yes. So we've had a baby that was born, ended up down there with an imperfect anus because there was no exit route open. The cord, do we have 2 cords or 3 cords? I mean, do we have 2 vessels or 3 vessels in the cord? That's going to be really important. Most of the time, they're going to know that though with ultrasounds beforehand, but sometimes not. Do we have an abdominal hernia? What is an abdominal hernia versus umbilical hernia?
Abdominal is bowel loops. Usually.
Inguinal. Abdominal.
Is that like how it works?
So we know we've got this phagic, right, covering our insides, and it doesn't always meet. So we may have this thin little line through here where the fascia doesn't meet, and when they strain, it pooches up, which is in line with the umbilical cord because the umbilical cord comes through that as well. You just kind of have to watch that. Sometimes it freaks a parent out, and you just got to make sure that you kind of outgrows that. So let's talk about genitalia. You get all kinds of interesting things. I would say it's about 50-50 now for the boys, whether they're circumcised or not, what I see. And if a family's never had a circumcised child, that's a whole different education to keep adhesions from happening after they've had their circumcision. It's very interesting. It looks, has anybody ever seen a fresh circumcision? Yeah. So they're really red, they're really swollen. You think, oh my gosh, how does this child pee, right? They're, like I said, the penile head is just really swollen and it's red, and then you get slough tissue on it. And parents are like going, oh my God, what did I do to my baby? But it goes down, and as the swelling goes down, then you have to teach the parent to keep the foreskin pulled back so it doesn't stick to the new skin. When that happens, then I have to come in and pull it apart, and it's not pleasant. So, and that's what I tell them. I said, you don't want me to be the one to have to come in here and pull it apart. Now, hypospadias is one of the things that is a common congenital anomaly in that part. And sometimes you want to be able, if they're not going to circumcise, you still want to be able to pull the foreskin back far enough to be able to see the urinary meatus. If you pull the foreskin back to the edge and you can't see the urinary meatus, there's a good probability that they've got a hypospadias. Now, what they don't want done anymore is they don't want those babies circumcised if there's a potential that they have a hypospadias. Because what are they going to do when they get ready to repair it? They're going to use the skin from the circumcision to repair the hypospadias. So, very good. All right. Females are going to have engorged labia. They're going to have a white discharge. That is normal. We're going to teach parents not to wipe that off. That needs to stay there. That is a hormone response for mom. And that new baby girls may also have some bloody discharge, and that's normal as well. And that's just response. Also, we're looking for any dimpling at the top of the luteal crevice or any open holes that you can't see the bottom of. Those need to probably be ultrasounded just to make sure that we don't have what? Tethered cord or spine bifida. Very good. Okay, you're also going to look for skin tags, even around the rectum and in the anal area. Okay, hips. we're gonna check, oh, I'm sorry, I'm bad. The back, yeah, we tufts of hair. Hips, we're gonna check for symmetry of the thigh folds. We're gonna do ortolani's and Barlow, which is checking to see if the hips push out of socket and as we turn them, will it pop back into socket? If you have a baby whose hips pop when you do that, then they need to probably have an ultrasound to make sure that they don't have other like developmental dysplasia of the hip, DDH. We used to call it congenital hip dysplasia. A lot of times these sweet little babies may already have really long nails. And parents want to cut them because they're getting scratched every time and the baby's scratching himself. Actually, it's better if they file the nails and try to cut them because cutting them causes cuts in the skin. The section in the book is really good for skin conditions of newborn, be it the jaundice, and that's what I'm going to talk about. We talked a little bit about that earlier. There is a nomogram, and this is on page, you're going to see it on pages 86 and 87. There's one on each page. And the nomogram helps you to know, is this significant? Is this bilirubin significant enough? Does it need to go under lights? Does it need to just be monitored? And it depends on how many hours out it is. So review that. That's going to be really important. Also, you want to look at the different types of Billy issues on table 9.4, page 85. And then also the last thing we're going to do is we're going to assess the caregiver. Does the caregiver interact with the infant, or has she laid him in the bassinet and got her phone and not paying any attention to the baby, especially when you come into the room? And then the other end, you may have the overzealous parent that may ask you so many questions. We talked about the Edinburgh postnatal depression screening tool, how important that is for us. All right, so let's move into the first year. Any questions about newborns? Like I said, it's a lot today. I want to take a deep breath for a second.
Question.
Yes.
When are they supposed to be circumcised?
Oh, babies can be circumcised at any point after birth. So usually if it's done at the hospital, they're going to be done in the first 48 hours of life because most normal delivery babies are not going to stay at the hospital much longer than that. But they have to be deemed hemodynamically stable before they can be discharged. So it's going to be done at least 4 to 6 hours before they go home. Does that make any sense?
And I know a lot of doctors don't even do it unless they've had their 5 shot too.
Good point, which is going to be done at delivery.
Right.
And if you've got a baby with an issue, then especially like you could proceed hypos babies, it may not be done until later. Now, the interesting part, if they leave the hospital and decide they want it done later, then it's considered a surgical procedure and it's a cosmetic thing.
And insurance probably won't cover it.
Insurance doesn't cover it.
Oh my gosh.
Isn't that stupid?
That's crazy.
Uh-huh. Yep. Yep. Now, in the cases of babies that go into foster care, that is not the case. Or being put up for adoption because those decisions aren't made, something like that's not going to be made by the state. That's going to be wait and see what happens. Does it go back to the parent? Blah, 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 blah. Then you have a different scenario altogether. That was a good question. Anybody else? All right, let's move into the first year. Table 10.1 on page 94, 97. It's very important. This is what you to expect in growth and development. As I've already talked about, first year is all about physical growth, weight, height. They should double their birth weight around 5 to 6 months. And that's what the book says, but it's more likely in today's society that they're going to double birth weight by 4 months. Most of the time, sometimes by 2 months. Yeah, those are those chunky babies. And we would like to make sure that they've tripled their birth weight by 12 months of age. So if you have a 7-pound baby, he should weigh around 20 to 21 pounds by the time he's a year old. And as this, we do well child exams at birth, and then we usually recheck a weight around 2 weeks. And then 1 month, 2 months, 4 months, 6 months, 9 months, and 12 months of age. So a lot of visits the first year. So developmental red flags. The growth charts I was talking about earlier, which if you have an EHR system, usually if you've got a PDA, that's going to be as part of your EHR, and you can show the parents how they're doing, how they're maintaining their curves. And each one of those, the head, the weight, and the height, all have a different curve. And you're going to see where it's going to go really sharply up the first 12 months. And then it's going to kind of slow out. It's still going to continue to go up, but it's going to flatten out just a little bit. We want to see these babies growing on a consistent pattern. And if they were preemies, we want to see them coming to hit the growth chart because they're going to be underneath the growth chart. And we want to come, but we want to see both the height and the weight coming up together to hit the growth chart. So watching for drops in percentiles or flattening of the curve is very important. So now, if you're looking at this kid, this baby, and what the growth chart says and what you're seeing are two different things, then somebody screwed up. Somebody did not get that baby stretched out correctly or got them stretched out too far, pulled them down, and they're 3 inches in, from the head when they did the length. Head circumference, if they don't get it in the right place, then that can be abnormal. So knowing how to do your vitals and to do those things are going to be really important. Like I said, reweigh, remeasure, redo if you don't like the looks of what it says versus what you're seeing. Okay. All right. Other reasons for red flags. Maternal depression, we've already covered that. Prenatal issues, we talked about that. Lack of education on how to care for an infant, we've talked about that. Substance abuse, causing neglect, socioeconomic issues, income, appropriate housing, access to transportation. And I'm supposed to tell a story, and I cannot. I'm reviewing these notes. It's like I cannot come back up with who KM is and why that was important. And that's the reason I really wanted the audio version from last year so I could review. I don't know who KM is and what was so important about the socioeconomic issues.
I'll see if I can find it.
Oh, I'm so sorry. But that was important. I've got little cues in there for me because I have ADHD really bad. So I have to give myself cues so I know what to talk about. All right, so other reasons for red flags. And I talked about one about this baby today. Reflux. This baby's having significant reflux and it's causing drops in percentiles of his weight. Birth defects, of course, are really big red flags. So in that, let's talk about infant mortality. Our rates have declined significantly since 2005. So we've gone from 6.86 to 5.82 per 1,000 live births. That's a 15% decline. That's huge. What do you think are some of the reasons that we've had such a decline? Anybody?
Better access to healthcare.
Better access to healthcare is one. What have we started doing that we used not to do with babies? Back to sleep. One. What is that supposed to help prevent? SIDS. And since we've done the back to sleep program and having babies sleep on their back, we have seen a huge reduction in the number of SIDS cases. And I think that is a huge contributor to our decline in infant mortality. Of course, we still have significant disparities in the rates of infant death in our minority populations. And who talked about chronic stress earlier? We're going to talk more about that, but that is significant as part of this issue. And what is chronic stress? And we're going to define that later, either this or in the infectious disease PowerPoint. I thought that was my thing. Maternal age factors are a huge portion. Yeah, we have more deaths with children born to women under the age of 20 and over 40 than the other age groups. We have, and it's classified, we have sudden unexpected infant death, and that can be from different kinds of things. And there it talks about suffocation, strangulation, motor vehicle accidents, ways that infants die that aren't disease related. Then we also have SIDS, which we've talked about, and that's a subcategory of the SUID. It's specifically defined as an unexplainable infant death after a full investigation. And we've talked about that. The Back to Sleep program has really dropped that. 90% of SIDS deaths occur before 6 months of age and usually peak in the 1 to 4 months. Why is it more so in that 1 to 4 months than in the 5 to 6? What do they start doing? They start rolling over. And once they start rolling over, you really can't control them and make them sleep on their backs. But you don't want anything in the crib with it. So then that becomes the suffocation and the strangulation. But if they can get into a situation where they're maybe up against something, they're able to roll enough to where that they can get out of that situation. Causative factors that they have found for SIDS: decreased arousal, asphyxia, and rebreathing and thermal stress. So these babies get too hot and they're rebreathing their own air. So the other thing that comes up are bruies or ALTE. I'm an old fart, and that was called ALTE when I went through school. It's now called a bruit. A brief resolved unexplained event, and the ALTE is apparent life-threatening event, and it usually happens in infants where the child quits breathing and then returns to baseline with a normal history and physical exam. So I'm going to tell my story. I was working in Eastern Kentucky, in Canton. Who knows where that is? You know where that is? So I was at work one day and I was in a room, and one of my nurses came out and said, "I need you to move." Okay. Excuse me, I'll be right back. This baby had been born. Mom had not realized she was pregnant until she was 7 months along, and then the baby was born early. They were impoverished horribly. They still had dirt floors in their home, and you all don't think in this state that we still have that, but we still have that in places. Mom had brought the baby in she'd had a normal appearing delivery and hospital course. I had seen the baby post hospitalization. They were back in for their 1 month checkup. The mother had come to the nurse when she came to the door to call somebody else back and said, "Do you think my baby is blue?" And so she immediately got them back. They put the O2 set on. They immediately come and got me. Heart rate was one in the 140s, but this baby was blue. And I thought, I looked at the O2 set, it said 46. I said, "Oh, there's something wrong with, you got it on wrong." You adjusted it? Not. So I start listening to this baby. It was just laying there. Just laying. Listen. Got a heart rate going. And then finally this baby had not taken a breath. That was, so it's like the OS. So start monitoring very closely. We're still dropping O2 sets. Heart rate now starting to drop. Of course, what is the first thing we did? It's like, yeah, get the ambulance here to the office now. Because we were an hour plus from Lexington. We were 45 minutes from Winchester, which had another decent hospital. We were 30 minutes from Kentucky River Medical Center in Jackson. So we weren't close to anything. And so I realized, I started having to do mouth to mouth or respirations on this baby. So as I just started doing my puffs, and as long as I was puffing, heart rate came down to a normal level, O2 sat came up. And then the baby finally started breathing on its own. By the time the ambulance got there, that's the way it works, right? Emergency's over by the time EMS gets there. So we had checked the glucose. Glucose was normal, so it wasn't, that hadn't caused it. We've been blowing oxygen. Then we started blowing oxygen in the baby's face, just trying to keep that going and getting it out. So the ambulance took her out, and before they got her to the ambulance, she tanked again. And so they called UK. The baby buggy was out, and so was the Peds helicopter was out on another. But they sent something, and they used the high school football field, which was right up behind our office, to land the helicopter, and we heard it come in. And then we never did hear it go back out. And the next thing we know, they've taken the transport team had gotten off the helicopter, gotten in the ambulance, and they went to Kentucky River, which is the other direction from where they needed to go, because the baby wasn't stable. Baby wasn't stable enough to get on a helicopter for some odd reason. This is the story that they tell us. I'm just glad the baby is somebody else's problem at this point. But it shook me. It shook me really bad. And so this baby finally gets to Lexington. There's a long story. It took 4 or 5 hours to get the baby stable enough at Kentucky River before they could get it to UK. So they get it to UK, and guess what happened at UK? Nothing. Breathing fine, didn't have any more episodes at all. The NP in the PICU keeps me informed about what's going on, how the baby's doing. Baby comes home, no more problems. Until she's 4 years old, and I'd already left by that point in time. And the colleague that I was working with at the time says, I just wanted to let you know that so-and-so they found dead this morning when they went in to wake her up to go to preschool. Not another problem. So breweries, and I've got a couple of kids in our practice that have had brewery events. It scares me to death every time they come in the office or they come in sick. I think, oh my God, we're gonna quit breathing again. So breweries are something that you need to be familiar with, and know that just because that they quit breathing doesn't necessarily mean that you're going to find anything wrong with them. So, all right, questions about the first year and infants. Anybody need to take a break? Are we good, or when we keep going? Okay, 5 minutes.
Elizabeth, how do you educate your parents for breweries? You know, so that they feel.
That's a good
prepared at
question.
home.
You know, after they've had one or before?
After they've had one.
After they've had one.
I know it's probably specific to what happened, but I'd be scared to death. to
They're-
get that child
and they
home.
are scared to death. Most of them end up with an owlet. That, you know what an owlet is?
I think I do.
An owlet is a O2 stat that they can put on their baby that they can wear at night when they're asleep.
And alarms.
And it alarms,
Gotcha.
yes, that drops below a certain, and they basically keep the owlet on them like 24/7.
Could they do like, is this like a sleep apnea? Do they have like baby CPAPs or something?
Well, if it's a true brewery, they're not gonna have any more.
Resolve.
Right, it's gonna resolve, and you're not gonna have continued problem.
Yeah.
If it's something else, then they're gonna have a diagnosis with which you can deal with.
Did they do an autopsy in that particular?
I don't know. See, I was gone, and like I said, my colleague just called them to let me know. You remember that baby that quit breathing? You know, she's 4 now, and mom woke her up, went to go in this morning and get her and to go to preschool, and they found her dead.
It's just heartbreaking.
It was.
So have you seen instances where the outlets have really been?
Helpful?
Yeah.
Uh-huh.
Okay.
It would be one of those things that I would recommend to any parent who's got a preemie that they're taking home. Or any kind of breathing, respiratory kind of issue. Yeah. Because I was like, oh, they've been so, this baby's been really congested and they're not breathing good and their O2 sats are dropping. It's like, well, how do you know their O2 sats are? Because I got an outlet. It's like, oh, okay, well, what do they drop down to? And they'll tell me. And so we actually have factual information that we can work with then. And when this baby in front of me looks fine. All right, I'm gonna move that. Am I boring you all to death? You can tell me. It will not hurt my feelings. Am I boring you to death?
I'm sorry?
Am I boring you to death?
No, I'm not boring at all. Just too much water.
Huh?
Too much water.
Oh. I thought you said too much work and I'm like going. Got two more, come back.
I think we're missing
Three.
3.
Let me breathe for a minute.
We shot on the back of the truck.
Well, yeah, it just didn't work. No.
I've got one more.
One more. It was fall.
Never.
All righty, let's talk about toddlers and preschoolers. It's the age group from you know where. Especially preschoolers. How many of you here are parents already? 1, 2, 3, 4, 5. Okay, the rest of you don't know what you're missing.
After having this class, I'm scared.
Nah. Nah. I haven't gotten that far yet. I cannot get them motivated. Cannot get them motivated to have a baby. It's like, look, you've got built-in health care and child care, and that doesn't help yet. But oh well. All right, toddlers and preschoolers. A little bit of difference here. Of course, the early toddler period, they're still pretty fun until you get to that 15-month-old that's no and already got an attitude and throwing temper tantrums like we talked about earlier. We've already talked about the fact that the first year is all about weight and length, and the second year is all about cognitive development. Even though they're continuing to grow and gain weight, they learn to walk and talk, climb, throw, manipulate objects, feed themselves, drink from a cup, scribble, color, usually in the places that you don't want them to scribble and color. That's a whole nother story. You just need to take a deep breath when you get out. Now I know why the little coloring books with the markers that only show up when on the paper. There's a reason for that. That was developed. Somebody like me ended up with Sharpie all over the wall. So older toddlers are much more engaging in their environment. They want to see how everything works. No offense to the males in the class, but boys have a tendency to want to take everything apart so they can see how it works. That is part of their genetic makeup. Some little girls are like that, but I've just seen more that happen more in the boys. They've got to see how it works. They don't grow up, some of them don't grow out of that. They got to take it apart and figure it out. And that's okay. But also they go through stranger anxiety during that first or that second year a lot, and they don't want you to touch them when they come in to be examined. You'll start to listen to them and they'll go, no, push you away. Or you start to touch their back and they'll go like this. They don't want you to be touched. So I do a lot of things in mom or dad's lap and not on the exam table, just to try to promote comfort for the child, but that doesn't always help. Then I've got parents' arms to hold when they have to. I try not to restrain a child myself. I always get the parent to do it as much as possible. Preschoolers, why becomes their favorite word. Why mama? Why mama? Why daddy? Why is that? Why is that? Why do they do that way? Why? Well, why are we doing this? It will drive one insane. So table 11.2 on page 111 talks about gross and fine motor development. That is a table that you probably want to review really good. Language is a significant milestone during this period of time. It's going to vary a lot. Girls usually start speaking much earlier and have more words than boys do. And we would like to see them having 2 and 3 word sentences by the time they get to age 2. I've got several that aren't. We start talking language issues at 18 months. There's a lot of times we'll monitor that from 18 months to 2. And if by 2 we haven't seen a huge improvement, then that's when I'm going to send them to First Steps as an initial referral for evaluation. Then you've got some sweet little children that by the time they're 15, 16 months, they're putting all kinds of words together and they're little divas. And that's so much fun. Now, our children in bilingual homes, if they're getting a good mixture of both, more than one language, it may take them a little bit longer to actually speak, because when I have a huge population of Hispanic patients, and I love the Hispanic families. And so some of them speak no English at home because mama no habla inglés. That's all that they're getting at home. So they'll speak, of course, Spanish. And so if I look at mom and say, ¿cuántas palabras? How many words? Okay. And they say, English? I say, no. Spanish, español. And they'll tell me, they say, no English. I say, okay. I don't care if they're speaking English yet, but if somebody else said the more they're around both languages, it's just a little bit more delay in when they actually start speaking. And when they start speaking, you tell families that they may mix it all up. There may be this Spanish word that comes out with this English word and so forth and so on, but their brains learn to differentiate it. So if there's the best time in life to learn a second language is when they're babies. So, and if you are not bilingual, you could be like me. I am 58 years old tomorrow, and I am learning Spanish. I work on it every day because of the population that I see, because if I don't, I very seldom have a resource for which to communicate with my parents. And if they don't bring an interpreter, I ain't gonna get one.
And the language line takes too long.
Exactly. And it's expensive. So it was either learn it or not. So that's me. That's the way I am. I want to be able to interact with my parents. So if I have language between us, then I'm not developing that relationship with my parents. So, and I've got some that speak really great English, but they let me practice my Spanish and they correct me in my sentence structure when they come in, because they know we're going to practice. They're going to let Miss Elizabeth practice her Spanish today. So it can be interesting. All right, so that's that sidebar. I also have not as many as I did, but we have a significant number of Arabic families, students they're here, students. And so if it's a dad, that's the student, there's very limited English with the mom. And usually dad will come and interpret for the mom. And that can be really interesting, but from a cultural perspective, and we'll discuss that in a few minutes. So language is a huge barrier. I have some refugees from the Congo that I'm very thankful that they've had an interpreter. And now the children of this one family have been here long enough that their English is so good. And you're really not supposed to do that. You're not supposed to use a child in the family as an interpreter. I don't care. This is an older child and mom brings her as interpreter, which is great. I'm going to use her. I'm not going to waste time, but everybody to each his own. So, all right, let's move to potty training. Wonderful subject. Table 1111 on page 123. So you've got some of these 18-monthers that are already, they're going to the potty, whether they're in daycare or whether they're at home with mom, it don't matter. I have found that doesn't matter. And you've got some 5-year-olds that are just getting number 2 under control. Some are much slower to train than others. So it's because of the neural development between the brain and then the bladder and the anal sphincter. And that is a really important factor in being able to control bowel and bladder. Now, the problem with potty training, and this is something that I deal with every day, multiple times a day. Once they learn to hold it, they hold it. And they hold it. And they hold it. Because they don't want to stop playing. And when they've held it so long and they have to go, it hurts. And they scream, so they hold it some more. And then their little bellies hurt. And mamas bring them in because they've got this belly pain and they're screaming. And it hurts to pee. Because it's putting so much pressure from the colon on the bladder. So constipation issues are a huge, huge problem in pediatrics among our toddlers and young school age children and our older kids. Since Christmas, yes, since Christmas, I have had to admit through my doc, a young man, 11 or 12 years old, good size, probably 175, 180, big, tall kid, to admit him to have a Go Lightly clean out with NG tube down because we could not get him cleaned out any other way. That's gross. He said it wasn't pleasant. I said, I told you it wasn't going to be. But Mom was adamant, we are getting this taken care of. Like, okay. And Miralax, what are we going to do? That's a whole nother discussion, and we want to get to GI. But you just have to realize and talk to these parents that they've got to go. You can't, even though that you're potty training, they have to still go potty. You have to stop them from their activity and make them go potty, or you end up with UTIs and you end up with constipation issues, because especially little girls will hold it to the point they're pee and not go, and they won't empty well. And that's another problem with constipation, is they put so much pressure on the bladder that they're going frequently, but they're not emptying completely. So, and then so when that urine sits there and becomes stasis, what happens? We get the urinary tract infection. Or we leak a little bit because we're not wanting to go poop. And so what happens then with our girls? We get an E. coli UTI because of the stool contamination. It's just a no-win situation. And teaching little girls how to wipe is really important. So you may have to have that conversation with the parent. Make sure that they're wiping front to back. Oh, hadn't thought about it. Okay, so developmental issues. Partially can be, dealing with siblings, both younger and older, can be an issue. It can actually retard development or increase it faster. You've got little girls, especially, will play mother hen to babies and pretend to be mommy. And then with that smaller child, that younger child, then if big sister or big brother is anticipating all of their needs, they have no reason to talk. They have no reason to do things for themselves. So sometimes we have to have a sit-down conversation with mama about, okay, he's behind. Is sister? Yeah. Well, we need to have this discussion with sister that she doesn't need to do that. And we need to have some intervention here. We've got to make him do or her do. We've talked about temper tantrums, and there is a difference between discipline and punishment. If you don't know, you need to look up the difference between the two. Discipline is that you're training them into where you want them to go and helping them to see where they have missed the mark and pushing them in the direction that you want them to go. Punishment is just, you screwed up. Now, I could go there, but we aren't. I have to be really careful. Sometimes they need to be punished, but constructive punishment, okay? They need to, and that's part of discipline. Constructive punishment is part of discipline. So, but a little one doesn't necessarily understand reasoning. You cannot remember your operational stages. Remember your child development theory? You can't reason with a toddler. You cannot reason. They do not understand reasoning. They do not understand, the consequences for behavior unless it's a negative consequence for behavior. Okay? So you're going to get to sit in timeout if you do this again, or you're going to get this toy taken away. So things like that. So it has to be appropriate. And dealing with the temper tantrum. Woo-wee. All right, food jags. Food jags are very, very common in our toddler group. They want one food and one food only, but they'll eat that food today, but they won't eat that food tomorrow. They're too busy to want to stop and eat with the family. And so they'll graze. Also, we have a new generation of kids that going from one activity to the other or being in daycare and coming home, we sit in the car to eat. Supper, especially, or breakfast, a lot. It is what it is. But try to have some sit down food times where we're getting a good variety of foods. But that's something we have to talk with our parents about. Dental visits and brushing teeth, of course, teeth start erupting during this period of time. It is recommended that they have their first dental visit by 18 months of age. A lot of our parents don't do that, but they are brushing teeth. Night terrors, restless sleepers, transitioning to toddler beds, moving to a different room. Though all of that can affect a toddler's sleep. And the toddlers are the worst about getting up and getting up and getting up and wanting to be in bed with you and wanting to be in bed with you. And you pick them up after they go back to sleep and you take them back to their bed and you wake up again and they're right beside of you. You pick them up, take their bed again and they're right beside of you. It makes for sleepless nights or very uncomfortable nights, but this too shall pass. So you need to be able to discuss night terrors with parents and that restless sleeping and the transition and not giving in to letting them sleep with you all the time so you can get some rest. And the book is very good about talking about sleep. So that's a big developmental issue. Social emotional, this is when they start developing peer relationships. So some are daycare, some will start preschool, early sports activities. We seem to be putting them into sports earlier and earlier and earlier and earlier, and maybe into sports that really they're not ready for. But that's one of my pet peeves. Whole nother lecture. But they do. In doing, they learn social rules of conduct and how to work as a group. And they may not learn the sport or do anything with the sport, but they are learning how to participate in society. During this period of time, they are becoming enamored with their own bodies. And like I said, they're going to play with body parts and you have to move through that. And they are going to move toward more independence and thought processes and choices. But toddlers and preschoolers thrive on routine. The more routine they have, the better off they're going to be. They know that they're going to get up at a certain time and what the breakfast ritual is like. They know what the bath time ritual is. They get a bed, we get a book, we maybe have a snack, and we brush our teeth and go to bed. So anything that disrupts that routine does have significant issues socially and emotionally. So if they have a very scattered toddlerhood, I had a situation with a parent last week with a 3-year-old. Mom and dad share custody, and that happens. And I'm not saying anything about that, but they have shared custody and mom and dad work together. Okay. So it's not an issue of that there's animosity between the two parents. They're working together, but 50% of the time the child is at dad's and 50% of the time the child is at mother's. And so this kid ends up severely constipated. Why? Control. He has no control over his life. And Dad and I had to sit down discussion and say, is it a control thing? And he says, I really feel like it is. And Mom and I have had that discussion. We really feel it is because none of the rest of his life, he's back and forth. He has no control over anything, but he can control whether he goes to poop or not. Okay. So they're talking about that and they're working with that. And that's just one simple example of some of the social emotional issues that can happen when there is not a routine. So Healthcare maintenance. In this age group, we do well child exams at 15, 18, 24 months, 2.5, 3, and 4. And then at 3, it actually starts once a year. Some of the screens we're using the ASQ. We're doing that at 18 and 30 months, the MCHAT, the lead. We're going to be doing school physical exams, starting with our 3 and 4-year-olds. We're going to be doing hearing screens with audiometry. And we now have what they use like at the hospital when they do the newborn screens. We do. They also have the old fashioned ones where you have to raise your hand. Your 3-year-olds can't do that. They don't understand it. Or you'll look at them. I've had staff that will say, "Do you hear the sound? Good. Do you hear the sound?" I was like, that is cueing them. That is not knowing whether they're hearing or not. You're cueing them. So with the new, we have the they're cueing them to say it correctly. So with what we're using now, it automatically tests, just like they do with the newborns, and they don't have to raise their hand. They don't have to participate at all except be still, which is amazing. So we can check their hearing and get a better hearing test with the omitted acoustic emissions test, the OAE. So, and then we also do a electronic vision screen. How many of you have seen that? We actually we have this machine that we take a picture of their eyes and we hook it up to the internet and it transmits to ophthalmologist, and they look at the retinas and you can tell us if there's some astigmatism, if they're hyperopic or farsighted or myopic, or if there's any kinds of issues, which is great because now we can tell earlier. We don't have to wait until these kids can look at the distance chart. If these kids are having problems, and what do we say earlier? Earlier interventions makes better outcomes, right? So we have found a lot of kids with eye problems earlier because of that. Red flags, table 11.12, on page 126 and 127. You want to look at that. Hitting and biting family and or playmates is a big issue. It is a big red flag. Something is going on that's stressing that kid out, that they're acting out aggressively. Getting to sleep issues. Not only do they wake up a lot of times, you have a hard time getting them to go to sleep. Routine's a huge thing. You're going to start seeing early signs of ADHD and ODD and some other mental health issues during this period of time. There have been times I've looked at a baby from the cradle and said, okay, that one's going to be ADHD. We're going to have that one on meds. You're going to notice more signs of autism, issues of not wanting to self-feed, things like that. Those are big red flags. It's my turn to take a break for just a second. You can talk for just a second.
So anyway, has anybody checked their weather app to make sure those that are farther away that there's not any change in the weather? I just want you to check Hawkinsville, E-Town, Lexington, that direction. Just make sure weather patterns haven't changed if you are driving a long distance. I think it's probably warm enough, but
Yeah. So we should be fine.
is it supposed to be cold where everybody is tomorrow? How long is it staying cold in your areas? I think it's supposed to be pretty verb tomorrow. Lovely. while we're waiting on Elizabeth,
Well, we're waiting on me.
is everybody making progress on thinking about their projects that they're gonna be doing for their DMP? Working, for their final paper, working with your advisor? Anybody, how about we go around the room and everybody just say what their project is?
That's a good idea.
Mine is, like nurse practitioners or primary care providers, knowledge on assessing anxiety and depression.
Interesting.
Yes.
I am doing, the action practitioners for also rescue kids in Kentucky, for who are this here.
I'll be involving, education and, test with the nurses and the.
Mine is improving colorectal outcomes for the COVID laparoscopic.
Oh, yeah, that's right. You don't have to do it. You're lucky. She's graduate, she's certificate. I keep forgetting that. Heather?
Mine's engagement of self-care by nurses.
Ooh, very good.
I'm self-caring right now.
When I did my first master's, I did, referral to, for primary care to refer to nephrology sooner, so that they can get dialysis, get access to type person in, catheters, so that they have an increase.
Interesting. Bailey?
Mine's gonna be on like, nurse practitioners, screens of, Down syndrome patients for early onset.
Courtney?
Mine's a program for homeless and immigrants here in Bowling Green to help decrease the, EKA readmission.
Very good. Lisa?
I'm trying to find out why college athletes are not seeking mental health.
Oh, very good.
Brad?
Perceptions of nursing as a career choice.
I
was laughing at it too when I first started thinking about it, but then sure enough COVID hit. I was like, I got my research study now.
Maybe you need to interview me over the years.
Belinda?
Okay.
Understanding sexual, education, sexual activity and unwanted.
Interesting.
Sarah?
Ooh.
Jordan?
As a program to identify cardiovascular risk factors.
Okay. So all of you also, just remember that you have a committee, your advisor is your chair. You need to be thinking about a clinical mentor, somebody that, it can be somebody you work with, like in Jordan's department, someone that he has for diabetes and then diabetic educator if you want, or whatever it might be. But you'll need a clinical mentor, and then you'll eventually be asked, who would you like to use as a second reader? And your second reader is somebody within the faculty that have taught you in this program, and you will discuss that with your advisor. But if you need a second reader, I'd be happy to serve as any of your second readers. So, when you get to that point, just be aware of those questions that'll be asked of you.
All right, I'm ready to move on. You all just, if I get diverted, then just be patient with me. I'm doing self-care today. I'm in the middle of an auction that goes off in 5 minutes. So
Tell them what your
my hobby, everybody's got to have something that they walk away from nursing to do to take the stress off. For me, I'm a quilter. Well, I don't quilt. I like to sew. So I cut material. That's the math person in me. I cut it apart and sew it back together in patterns. And I am on an auction for a sewing machine called a Singer Featherweight. Anybody ever know what I'm talking about? They're little bitty machines and they're very portable. And I have 2 more ready. But this one's a this was a 1941 that if I win this auction, I'm taking it to a friend of mine. And he's going to strip it down, paint it a new color, redo the box. It's going to be my showpiece. So when I go to retreats and stuff. So anyway, it needs a little work. So this is the perfect one to to get stripped. But if you just look at them on eBay or Amazon, they go for like anywhere between $400 and $700 for this little bitty sewing machine that was built in the 1930s, 40s, 50s, that has no electronic parts except the motor. And it's not electronic, it's just a motor. So, all right, let's move on. Let's talk about middle childhood. This is the best time. In my personal opinion, middle childhood is the best time because kids during this point, they are very eager to please. They're pretty cooperative. They're learning new stuff all the time. They want to please their teachers, which means they also want to usually please their parents. So you can give them the look, or you can frown, or you can snap your fingers, and you usually get a really good response. You get what you want. It's before they've gotten an attitude, a teenage attitude. So with that in mind, their bodies are not changing nearly as fast as they did in the early years. But of course, nutrition and activity is still very important. This is where they're becoming more involved in the sports and scouts, church, those kinds of things where they're learning those social norms and they're developing more specific, significant peer relationships. They get that BFF kind of thing going on, especially little girls, sometimes little boys, but more so girls. So your development and anticipatory guidance for this age group on tables 21.1 and 21.2 on page 130 and 131 are something that you're going to need to review. Some of the screening tools, you're going to look again on chapter 12. So table 12.4, page 135, are some of the different screening tools that you may use during this period of time. The Snellen, what's the Snellen? Eye chart. Usually they're old enough to stand and do that 20-foot thing at this point in time. You're going to do audiometry. This is where your SEDS or your pediatric symptom checklist are good developmental tools for this age group. Now the PHQ-9 is this. This is another one of those things that we're required. Starting at age 11, we have to screen our patients for depression and suicide risk. And these are standardized tools. The CRAFT, C-R-A-F-F-T, is a 3-question about drugs and alcohol use and substance use. And then the PHQ-9 is the 9th question. There's also a PHQ-2, and those are some of, but all of that is on your 547 resources. So that is there. We do that starting at 11. The scared. We have a lot of kids that come in with anxiety disorder, and that's becoming worse and worse and worse, or more frequent. How about that? I say that more frequent. Are we seeing kids come in with issues with anxiety? Verbalizing it. That's a good thing. Okay. If they're finally verbalizing that they have an issue with anxiety, and that means we're moving forward in those mental health kinds of issues, and that's a good thing. And they're telling parents, and parents are responding. So they're coming in. But the scared is what we do it's down to 42 seconds, and I'm just making sure I'm still the high bidder.
You pay attention to that.
Okay.
Here is uploaded
Right.
as well. I found that today and uploaded that the instructions, and I think it has. I put several things or looked at several things. I think it has the form with it as well, so it is there. And if you're out in practice and you and your preceptor come across a tool that you think is unique, you think it would be important for others in the class, please, if you have a copy of it, scan it, send it to me, or send me the name. I'll do my best to see if I can get my hands on it, because the more resources we have to help us in practice, the better we're able to provide care and make those earlier interventions.
Oh, wait a minute. I won! Yay! Okay. So we started class tonight. I looked at Dr. Blankenship. I said, I got one problem. I'm in the middle of an auction that goes off during class. So, okay, now we can move on. Thank you all for letting me do a little self-care. So, but we use the scared a lot. I use the scared a lot. It has a parent, did she say this? It has a parent page and our parent tool and a child tool. And you don't want parent and child to collaborate when they're doing this. And when you get done, you're going to know whether there are specific scores for generalized anxiety disorder, separation anxiety, social anxiety, and school phobia. So you can pretty much pinpoint what specific areas that they're having trouble with and where the problem is. And usually it's right dead on from what they're telling you. And then we can treat appropriately and get them in. If they're not, we get them in with a mental health person. And that's a whole nother lecture. All right. So the next thing down the list is the NICHQ Vanderbilt Assessment Scale, which is absolutely awesome. It assesses for ADHD, ODD, and OD, which is what's our CD. What's CD? Huh? Compulsive disorder, yes. ODD. Oppositional defiant. Oh, those are you just want to. But you don't, but you want to get them help. And that's the great thing about the Vanderbilt is because it can differentiate between ADHD, ODD, and obsessive compulsive disorder. So also you're going to check their blood pressure, their lead, you're going to assess them for STIs. Now at age 11, I have to document, starting at age 11, when they come in for their annual checkup, I have to ask them if they're sexually active. Yep. And I have to document whether they're sexually active or not.
Are they? You ever had one?
Yeah.
Wow.
Back when I was a school nurse, I had a 4th grader that delivered. She was supposed to be in 6th grade, but she delivered as a 4th grader. Now you're talking about a classroom discussion with a bunch of 8, 9-year-old girls. Their classmate was pregnant. That was tough. All right. So again, that's a whole nother topic. So during this childhood, we've got developmental issues of school adjustment, refusal, phobia, and that's huge. It can be a very huge issue, and it usually manifests in somatic complaints. My belly hurts, my head hurts, I don't feel good. And then as soon as the bus goes by or it gets that we know we're going to get to be home for the day, then they start feeling better. School avoidance. That's actually a diagnosis, school avoidance. Learning issues are going to come to the top, and it can be as simple as eyesight that they're having problems with. The Optometry Association did a very smart thing several years ago by lobbying and getting the state to say that a child has to have a full optometric exam before entering kindergarten or entering public school. That way we know ahead of time going in whether they start with vision problems or not. So as an old school nurse, it was my job to do a distance screen with preschoolers, kindergartners, 1st graders. And when I was with Warren County, I had 6 elementary schools to do that on. So I maybe missed a 1 or 2. So anytime there's learning issues, it's really important to work with the parents and the school to make sure that testing gets done. And we have to find out from the provider end, whether it's organic cause or whether it's an instruction issue. And sometimes that can be a source of contention between you and school. Also, you need to look at table 12.6 on page 138, kind of review that. And that's all on the middle years. Any questions on middle years? Okay, let's move on to the dreaded adolescent. I call them hormones and tennis shoes. Puberty is a huge tough time. How many of you can remember your own puberty and all the emotions of up and down? And there's a lot of kids that have a lot of trouble navigating it. This is where they're moving from those concrete operations to more formal thought, and they have that ability for abstract thought. So the biggest change in your assessment exam is discussing the physical changes that's going to be going on with the teenager's body. Now, boys don't necessarily like to talk to this old woman about when she starts talking about checking doing the self-testicular exam, and we talk about why and the changes that are going, they get all embarrassed. And it's like, no, look, I had 2 boys at my house. I get it. I know what's going to happen. You're going to stink. Your pits are going to stink. Your feet are going to stink. Your arms get long. You fall over your feet because your feet get this big before you get up. So we talk all about it, and I talk to them in a language that it's kind of fun, that they understand. And I said, it's okay. That's going to be okay. You're going to be fine. Usually boys will gain weight before they do the linear shoot up, and girls will gain weight and develop hips as they start with menses. And usually girls will develop boobs 2 years before they start. They'll start the boob production about 2 years before menses starts. So you can use this in your discussion. And you also I look at mom and say, okay, mom, how old were you when you started having your periods? That's a really good gauge of when their daughters are going to start. If you've got a girl, I've seen little bitty skinny girls start their periods, and I've seen bigger girls with more flesh on them not have their periods. So there's no rhyme or reason to it. They used to say that you had to have so much % body fat before it would do it, but I don't even think that's a rule anymore. I think that's went out the window. That's not what I see. Tanner stages. This is really important. Table 13.1. Tanner stages. Those are your sexually development stages. Girls have 5 breast stages and 6 hair stages. Boys have 5. 5 and 5. So with boys, it's hair development in the pubic area as well as the development of the scrotum and the testes and the penis and the changes there. Whereas girls, it's breast and then hair development in the pubic area. So need to review that. You need to kind of know those to a certain extent when you're assessing adolescents. As we've talked about, these are some of the things that we're assessing. We're going to do the craft and depression. You get that positive drug. It's like, yeah, I've smoked pot. Yeah, I drink. Tell me more about that. Do I need to be concerned? Do we need to send you, is this a big issue? And you've got a parent sitting there. It's like, okay. Now, this HEDIS thing is a great tool to help you, great acronym that helps you focus your questioning, because these are some of the things that you need to discuss. And you can do this while you're listening. Well, not necessarily while you're listening. You shouldn't be talking while you're listening. But if you're looking in their ears and looking in their eyes and looking in their throats, you can go through this in your head. It's like, oh, you live at home? Mom and dad, you got brothers or sisters? Oh, where do you go to school at? You got an after school job? Oh, what kind of things do you like to eat the most? If you can just move through that general conversation, and they don't even know that they're being assessed. Okay. And you've already done the suicide and depression because you've got the screening tool. You're just going to go over and the drug part. So adolescents are fun. Some of the red flags are going to be on table 13.3, page 156. Some of the different things that you're going to see on your physical exam, you may see more issues with scoliosis. And then you may also see more vision and hearing issues. Scoliosis is a big one. We start checking for that. I'm going to be honest with you. We start checking for that when they're little because that can be an issue. I've got a sweet little girl that's got idiopathic scoliosis and she's 4. She's got some other congenital things. She was born with, I got to think what the name of it is. transposition of the great vessels. So the aorta was where and the switch back and forth. And so she was flighted to U of L, and she had open heart surgery within the first 12 hours of life. But she is spunky, but she's got idiopathic scoliosis at age 4. And she's also got some other issues, and that's probably, I need to talk about that later in another lecture. But she came in for her annual checkup, and she wasn't using her left hand at all. And I see her frequently. And it's just like, Amanda, when did we stop? When did this start? She said, well, I really hadn't noticed it. She said, but you're right. She's not using, she would do everything with her other hand. And she would pick it up, she would pull it up, but she really wouldn't use her fingers. Now she has AFOs. Everybody know what AFO is? The little braces on the legs because of hypotonia in her legs. Anyway, from all of her other issues. But she runs, she can't keep up with her. But she never had any issues. No, besides having had to have the cardiac surgery, no other real health issues, no loss of oxygen that we know about, no other infarcts, no anything like that. Come to find out, after getting her to a specialist, she has cerebral palsy, a mild form, because of the lack of oxygen that happened from birth to getting her surgery done. Huh? Yeah, those 12 hours. I know that they were doing everything they could, but it did not show up until she was 4 years old, which is highly unusual. Okay, so, but as adolescents, let's go back to that. Adolescents are more likely to be engaged in risky behaviors. They're going to be your kids that harm themselves or others or animals. Their self-image is really poor, and this is really at times, and that's going to really affect their behaviors, their risky behaviors. If they have learning issues or attention issues, it's significant. It makes school just miserable for them. And then they'll usually act out. This is usually a time of, if they've got poor decision-making skills, they're going to make some really bad decisions and get in some really bad trouble. So adolescents are just a class of their own, and you have to change how you work with them. You can't treat them like children, even though they are. You almost have to treat them like an adult and give them more power and decision-making ability when you're assessing them and when you are teaching them. And you teach them and more than you do their parents. So when I'm sitting down and talking to that 16-year-old today about making sure that he checks his testicles at least once a month and how to do that, I was teaching him, because this is a health issue that could be a problem for you. This is not mom getting in the shower with you and checking your scrotum. This is something you've got to do, and you have to take responsibility for it. So putting more of their health responsibility on them is going to be really important. Okay, questions about development, red flags. I know you will later. So we're going to move on to an issue that I think is really, really, really important. And this is not just in adolescent health, but this is just in all pediatric health. So the American Academy of Pediatrics published in 2019, they defined racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks that unfairly disadvantages some individual and communities and saps the strength of the whole society through the waste of human resources. That's a whole lot of just basically to say it's a way of controlling people. That's the way I interpret it. That it is a social determinant of health. And if you all haven't heard social determinants of health in this program to date, that amazes me. Of course, it is defined by WHO as the conditions in which people are born, grow, live, work, and age. Okay. So as a social determinant of health, it's really, 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 and we talked about this and you brought this up earlier, chronic stress. Chronic stress is the impact of racism and on our bodies. living in conditions where that has been structured where you're at a disadvantage already. So it can cause, it's been linked to birth disparities and mental health issues. These constant issues with racism can cause prolonged elevation of stress hormones, and which is what? Cortisol, right? And that can lead to our inflammatory reactions. And it makes individuals more predisposed to chronic health conditions. Okay. So when you talked about chronic stress as something that can cause a birth, you are completely correct. So when we talk about racism, you need to look at yourself. You really need to take a hard look at yourself and what your biases are. Because racism, I guess we lump everything into racism, but what are your biases against other people? And how do you combat that when you walk in and you're seeing a patient? How do you separate your biases from being a care provider to provide the best possible care that you can to that patient? I know what my biases are, and I work on them all the time. I have to. Okay. I've got, to me, if I've got a doc that won't see a patient because they won't vaccinate, to me, that's bias. Okay. That child still needs care, in my opinion. And I want to be the one to provide that care. Maybe I can talk that parent down the road into doing vaccinations. But that child still deserves the best care that can be provided, in my opinion. So that's just an example of not necessarily race, but just a bias that can affect your practice as a provider, and what you can do about it. Let's see. So we were taught, how many of you were taught holistic, that we take care of the whole patient, right? That's what nursing is all about, right? We take care of the whole patient, not just the disease entity, but we take care of the whole patient, mind, body, soul. And so eliminating our biases from what we do is going to be very important in treating that patient with respect and what's the word I'm looking for? And dignity. You're doing all your stuff on long-term care. In my opinion, that's one of the biggest biased areas in lack of respect and dignity of our populations. So applause to anybody who works with that population on a regular basis. So just be cognizant. Maybe do kind of like a little self-inventory. What are my biases? Or am I racist in any way? Or am I biased in any way? Is it cultural? Is it socioeconomic? You know, we talked about the vaccine. So it just kind of sit and do a personal inventory. So that does affect quality of care. And we start talking about assessing quality of care. In pediatrics, we talk about HEDIS measures. Do you have HEDIS measures? I have HEDIS measures when we talk about quality. Okay. And HEDIS measures measure quality. I don't know how you measure quality. Do you know how you measure quality? Because to me, that's an individual kind of thing. But it measures also access to care and then member satisfaction. So our HEDIS measures that I have deal with this. Okay. And all the things that I have to keep up with. And then basically, I get a report card on every one of my patients that has a state insurance plan on how I am doing. How have I measured up against the HEDIS measures and what am I not doing right? I am kept accountable. I'm held accountable if my patients go to the dentist or not. I can talk till I'm blue in the face, but I can't do a dental exam. I am not a dentist. But I'm held accountable whether they go. And that's a mark on me if they don't go to the dentist. So there's some really weird things with HEDIS measures, but this is what we've got now. Okay. So here are our quality measures. Did they have their well child visits? Dental, assessments and screening, all those wonderful things that we've talked about. I have to make sure that I include in my note nutritional and physical activity counseling starting at 3 years of age on all of my well child visits. Yep. Chlamydia screening. We haven't talked about that. Girls 16 to 24 have to have at least a screening chlamydia test. So that's my job to make sure that they get it. 15 minutes.
Oh, so you think about everything that has to be included.
That's the reason I get there at 6:30 in the morning so I can prep my charts before I start, because I got 90% of this done before I go into a room. I have to, or I'm there till 8 or 9 o'clock at night.
For the well child visits, I work at therapy, so we still have like
Right?
family practice.
Right.
They do well child visits every year after like 1 year, I think, until a certain age. Is that correct? Or is that something that we do? Is that like
That's something
standard?
that you do. It's 1, 15, 18, 2,
Okay,
2.5, 3, and then at 3, it can start once a year.
gotcha.
That's the recommended.
Okay, gotcha.
So I don't know if they're meeting their HEDIS measures, if they're not doing the 15 and the 18.
No,
And
they're doing those. They have a lot of well child.
Uh-huh. Yeah. Yep. Oh, yeah.
And after all the ones that are recommended at early on, then they do one each year.
Once a
until
year.
18.
right. Yes, once a year.
Yeah, water pumps on those things, all right?
No, not mine. Good for you.
So in your EMRs, is there,
So I'm just looking at.
because Elizabeth and I work in the same, within the same system. So you're able to click on different things, or you have macros that you put in?
So for an adult manual wellness visit, not for children,
Mhm.
everything that Medicare requires us to speak.
Right.
Is in that
Right.
chart across the top, there's each bullet, and it's all there. You just make sure
Uh-huh.
you address those.
Uh-huh.
So you just pull over for each kind of visit. So like for well child visits, we have the template, and I mean, it asks all of those things on the screen.
Yes.
And then just go down.
I do specialty, so I don't have those, but.
I have developed with our IT person my own that have that all I've got to do is I've got to go in then and put the results of the test. I have an HPI that is a generic that goes in for each age range. It does make prepping my charts much easier. And if there's absolutely nothing abnormal, then all I got to do is put in the test results or the screening results, and I can hit sign and it's done. So yes and no, but I don't have prompts that automatically come up. I've had to design it myself, and that's okay. Behavioral health, we've got a lot of ADHD kids, and they've got to be followed on a regular basis every 3 months, and I have to pull Casper's. Everybody know what Casper is? Yep. I don't get to prescribe ADHD medication, even though I have a certification in pediatric mental health, because I am not a psych nurse practitioner. And if you are not a psych nurse practitioner in the state of Kentucky, you cannot prescribe ADHD meds.
I didn't realize that.
Correct.
Yes.
For longer than
What was
3
that
days.
news?
No,
What was that news
none,
that
zero.
passed About controlled substances?
I'm sorry?
Did that controlled substances just pass?
No, what that was that you may have heard about was there was an emergency use that was out that you did not have to have a controlled substance.
A Kappa CS.
And that was revoked this week. So you have to have a collaboration with someone for a Kappa CS now, like it was prior.
Yeah.
If your DEA, my understanding was you received a DEA in less than a year out of practice, yes. Your DEA was something was going, you should not be using your DEA until you're after a year.
Mhm.
No, I don't know about that. That's kind
Is it
of. Yeah, it's expensive.
Mhm.
Anyway,
And from my understanding, unless you can't even prescribe opiates for more than 3 days.
we
A
can,
Schedule
nurse
II.
practitioners cannot, we can prescribe hydrocodone for 30, but morphine, anything oxys, we can only do for 3 days.
Yep. So,
So when you do get to that point, and you'll have that class with me, in nursing 509, which is more advanced practice, and we will have different things on that. But I highly encourage everybody as a family nurse practitioner to be a member of the Kentucky Coalition of Nurse Practitioners and Nurse Midwives, because they help you to stay abreast of all the changes that are going on through their list of it.
Yes.
End of speech, but
That's being part of your profession.
professional organization.
Yes.
So a physician that doesn't have you have a certificate for mental health.
Mhm.
A physician who does not have that, they can prescribe.
Yep,
Yes.
and has absolutely no experience whatsoever.
Zero experience.
Zero experience. But he is responsible. I mean, when he signs that and orders it, that person is responsible for that. So, but I have a really good doc that I work with who knows how much I know about. And so she never questions me. I just send it to her and she sends it to the pharmacy. And I manage patients. I just can't, am not allowed to do it. So, and I fought that battle and I lost. Okay, so moving on, as far as other quality measures, like let's say you're coming in with an upper respiratory infection or a sore throat. If I prescribe you antibiotics and I didn't do a strep test, I get a ding. I just can't say pharyngitis without doing a strep test, even if positive or negative, I'm gonna get a ding. Same thing with asthma. We have certain guidelines with our HEDIS measures with our asthma management. I get dinged a lot on that because some of these older kids, if they ain't having problems, they ain't coming in. Or they're doing so well that they're not using controller med anymore. And I don't have any control over that. So I get dinged. Immunizations, they call it the combo 10 and then the adolescent. So all of immunizations, and that's a whole another discussion. So pull out this page that she gave you. Did you give them all
I
this
didn't
page?
give them that. It's in resources in 547. It's the
Okay.
latest CDC.
Yeah, we're gonna talk about immunizations hopefully before a little bit. But immunizations are a huge part of pediatrics. Okay, it starts at birth because they get their first hepatitis B in the hospital before they leave. If they sign. Okay, so immunizations start at the beginning. And so there are a combination of 10. Some of them are repeaters that they require us to make sure that they have in the first 2 years of life. Okay, that includes MMR, chickenpox, DTaP, polio, hepatitis B, hepatitis A, Prevnar, which is pneumococcal, and Haemophilus influenza in combinations thereof, I think, and rotavirus, and that's 9. What did I miss? I probably missed something. Anyway, so there's all these vaccines, and then adolescents are supposed to have 3. Now, 2 of them are required for school in Kentucky, so it's not a problem. The 3rd one is not. The 2 that are required is the diphtheria, tetanus, and pertussis booster, and the meningitis, so the Menactra, Menactra may be depending on which company you use, which has meningitis ACYW in it. All right, so those 2 are required. The Gardasil vaccine, Gardasil 9, HPV vaccine is the other one they consider part of that 3-shot combo. That is a at-will vaccine. I have a huge problem getting parents to okay getting the HPV vaccine. I have talked about, this is how it is passed by sex. Yeah, your 11-year-old may not be having sex yet, but they're going to, and they don't get it. They don't think their child's ever going to have sex. Or that they're going to have one partner, and that's the only partner they're going to have, and they're going to have that partner for life. And that doesn't, and I have to tell them that doesn't always happen, and it may not be your child's fault. And Mr. Wonderful may not be as Mr. Wonderful as you think he is. And it still doesn't help. I get pretty. But then you get to the point where you have talked, and you're making them mad, so I have to shut up and stop.
And you're wasting your.
I'm wasting my breath and my time. Wasting my breath and my time. We've had adolescents that want to get it, but their parents don't want them to get it. So he's looking to say, okay, when you turn 18, Mama can't say anything anymore. You can come and get it and we'll do that for you. So, and that's another thing.
Can't get that anymore?
Huh?
Is there an age where they can't get that anymore?
26. Yeah, they're gone from me by that point in time. They're on their merry way. Okay, so now all of this comes from this wonderful book. Now, this is the Bright Futures book. The summary of what's in here is here. So this is
We're not
what the
required to have
government,
that.
no, you don't have to have this book. This is what the government has used as the gold standard. Okay, now, you see how thick this is? Do I have time to cover all of this in a 15 minutes? No. So what you all are doing is you're getting the short version.
Or this one.
That's
This
what
is
you're
the
getting. This
recent
is-
one, and this is the one I've asked you to get.
This is the third edition, that's the fourth edition. Okay, but it really is not a whole lot of different. And this is your synopsis of growth and development, anticipatory guidance, those kind of tools that you should be doing. So now I have it not only in English, but I also have it in Spanish for me. So I can show my parents. Read it. Leo, you read it. And so that is what we are measured by. That is the gold standard for well child care across the country. Okay, I have thrown a lot at you today. A lot, and I've talked about a lot of different things. We've talked about child development. We've talked about racism, HEDIS measures. You're going to have a lot of questions. Look at the handouts that we've talked about.
If you have questions after you leave, after
Oops.
the reviewing,
Mhm.
Always feel free to email me and
Mhm.
I will compile and get to Elizabeth, or if I can't answer it or whatever. Okay.
Okay, chapter 22, immunizations. I have done a voice recording for this, so we're not going to spend a whole lot of time on it. Also, get your papers out, lay them out when you get ready to sit down and listen to this PowerPoint, okay? And then the PowerPoint from where?
Which one are you?
Oh,
Chapter 30?
yeah, where is it? Right there. There it is. Infectious disease. 125 slides. Okay. Yeah, like I said, take your time, go slow. Some of it you're gonna like flip through because I flipped through it. Okay. And then we're gonna go really quick. Do you have all of them up or not? Where you can get your grubby little hands on them, because I have the flash drive that you gave me that's got all the chapters on it.
You're saying all of them, which one were?
All the book, the PowerPoints for the book.
Oh, they're individually put here.
Okay, do you have, pull 14 up?
Yeah.
Because that's the one there it is. Okay. All right, this is 5 or 6 slides. Okay, then we'll be done. You still got 15 minutes. I thought I did pretty good, boss. Okay. So when we talk about, you need to remember that this book is written for pediatric nurse practitioners, both primary care and acute care. So it's going to talk a lot about the PNP, okay, and what the PNP does. This is the book for advanced pediatric care, okay? So, where's my slide? Come here. There you go. Okay. So, did you all know that pediatric nurse practitioners were the very first nurse practitioners? We started out as pediatric nurse associates, and they could be a diploma level nurse that got specialized training in pediatrics and could practice as what you and I would call a nurse practitioner today. Dr. Loretta Ford and Dr. Henry Silver started that at the University of Colorado. In my organization, she's considered, you know, the all to be all, hail to the chief kind of person. Now, the focus then was health promotion, protection, disease prevention, and we focused on healthy people goals. And healthy people didn't start this last 2 years ago. It started way back, 2000 actually. So now, what are we looking at? What's the focus? Primary care PMPs, which is what I am, and acute care PMPs. I am not an acute care PMP. I do not have the training or certification to do acute care. So I am not the hospital nurse practitioner. And in my profession, pediatrics, you're supposed to be acute care certified if you're doing tertiary and quaternary care. Let's see. So pediatric primary care, it's generalist care. If you are working in an office practice as a family nurse practitioner, that's the kind of care that you're going to be doing. And that's kind of what care we've talked about today. So as you can read through that, we always, of course, holistic nursing, because we're nurses, we're more person-oriented than disease-centered. We're looking at the whole person and how it affects especially with children, how it affects the family. How does this illness, how does what's going on with this kid affect the family dynamics? And we are emphasizing on health promotion and protection. That's the reason we do so many checkups and well trials and teach and teach and teach. So in that book, Bright Futures, those are the key themes throughout. And you can spend a lot of time reading and learning. It can be a class all in and of itself. What is the difference between primary care versus primary prevention? I mean, think about it. Primary care, I do that. Those of you, Karen, you work in the PICU, right? PACU. Okay, not the PICU, PACU. Okay, you're post anesthesia. Okay. But those of you who work ICU, work at a different level. If you're a nurse practitioner in those levels, that's going to be more of a tertiary quaternary care level, right? NP. That is that kind of care versus primary prevention is those efforts to keep disease processes from becoming established. So when I'm doing a well child, I am trying to provide care that's going to try to keep disease processes from becoming established. Okay, y'all can read through that. That's, whoops. And I told you it was a very small slideshow, very small. So just kind of review that. Know the difference. You might get a question about the difference between primary care and primary prevention and what the different levels are. Who knows what we'll come up with for test questions. We've covered a lot today. The developmental milestones, that looks like it's been typed back with an old typewriter, is because it was before we had computers. But this hasn't really varied. So this is a synopsis developed by my old boss as far as what are the things that you're going to see in here. So this will be a good tool to use when you're studying. If you've got all of that information in your book, you can break it down to mostly this. Now, does that mean you don't get to read? You still have the answer. You still have to read. Okay. Questions? Are you more overwhelmed than you were?
There is a lot of knowledge, but by the time you get to the first exam, remember, you're being assessed on your generalist knowledge.
Right.
It's not like it's microbiology,
Right.
we're down into the cell level.
No.
We are trying to prepare you to be competent to answer pediatric questions on the boards and care for pediatric patients.
Right.
Okay, so the other thing that I just want to grab, there's a new edition that has come out, and I'm going to get it. But I found this very helpful in peds. My review course that I did was through Fitzgerald, Margaret Fitzgerald, and she had a set of cue cards for both adults and children. And I remember it being very helpful in clinicals when I was for peds. It may be something that you want to look at. If anybody wants to look at this today, you're more than welcome to. It's just a suggestion. There's tons of resources and you can get overwhelmed with all the resources that are out there, but learning how to do a really good physical exam on a little one is so important because you just have that little snippet of a window and like looking at the ears. If you don't get it the first time, you may not get it at all,
Exactly.
you know, so you have to feel comfortable on how you're gonna do something. So anyway, questions, comments, concerns? All right, I hope everyone gets home safely. We'll be communicating by announcements. If you're interested in ICATs, reach out to me. If you have questions, I'm still here. Whatever, just keep us posted, but be careful getting home for us, okay? Thank you so much for your time and attention.
My ASQs, where did they end up?
Two right here.
Okay.
This is the 30 and the 9. Where's the 8